This lecture is on knee and thigh rehab, and today we are going to go over mainly general principles of rehabilitation, some exercises, some ideas of what you can prescribe, and then in part B of the lecture we'll go over some specific injuries and discuss some timelines and what to expect in rehab that might be different in different injuries to different structures. So knee and thigh. At the beginning of the notes here, I just put together some general points of interest, and these are from the book primarily. There's a lot of them in there, so I just chose the ones that I felt like were more clinically applicable. So the most functional activities are performed in 0 to 40 degrees of knee motion. So it's really important that when we're doing rehab with the knee that we need to get that terminal extension to 0 degrees and to get them to at least 40 degrees. And they'll feel like they're fairly functional at that amount of range of motion. Of course, they won't be able to do everything, but they should be able to at least walk and ambulate from one place to another. So 0 to 40 degrees. Just a note here on measurement of Q angle that it can change from weight bearing to non-weight bearing. And then what can affect the Q angle outside of bony structure? Used to be thought that the VMO, if it was weak, would allow the leg to kind of collapse into a valgus position, or pronation. Could certainly affect the Q angle. The line of thought currently that's being researched is weakness in the glute max and the glute med, that it can affect the weight-bearing Q angle. So, factors influencing post-injury strength, there's three primary ones. The first one is in edema, and you can see in this picture here that this patient's left knee has significant edema, and it's said that if there's more than 10 millimeters or milliliters of fluid in the knee, that it inhibits the VMO. And the more inhibition that you get of the quadriceps, then you get more pain. Then the pain will automatically cause a reflexive inhibition, which will show up significantly in the gait. So they'll have an antalgic or painful gait, which then can lead to more weakness or compensation. So those are the primary factors influencing post-injury strength. Under rehabilitation points of interest, I've just brought out three of them. One is to make sure that you understand what the term extensor lag means. A patient that has extensor lag means that we can extend the knee fully with passive range of motion, but they cannot actively extend the knee to 0 degrees. So if we see that, common exercises that we'll prescribe are quadriceps sets, short arc quads, straight leg raises, and then something called Tigney's or terminal knee extension. And I'll review what all of those are later in this lecture. Another concept that's talked about that's helpful to understand when we're talking specifically about ACL injuries is this concept of shear stress. Shear stress is the stress that takes place between the femur and the tibia. And so if we look at the knee and we see what happens when somebody contracts just their quadriceps, because the quadriceps attaches to the front of the tibia, we'll notice that there is actually an anterior tibial translation glide that then takes place if a person contracts just their quadriceps. In a knee, this anterior glide is checked or controlled by an ACL, so the anterior cruciate ligament. So you can imagine if somebody has a repair or replacement of this anterior cruciate ligament, then we need to be a little bit careful early in rehab on doing a lot of repetitive quadriceps sets, because the quadriceps will cause an anterior glide, and it can actually loosen up the plugs. You can see on this picture there the black markings where they've sutured in the plugs of the new replacement ACL. So we could weaken those with doing repetitive quadricep contractions. If we put a weight on the ankle in this position and have somebody do terminal knee extension, so they bring their leg from 90 degrees out to full extension to 0 degrees, we actually increase the anterior translation glide. So we certainly don't want to do that. To help us avoid this when we're doing ACL rehab, we'll do straight leg raises, so the knee will be in full extension. And when we add weight, it's added right below the knee, about right at the tibial tuberosity, in order to add resistance. So if you are asked to do isokinetic, so put an athlete on a machine after an ACL stress, will start at slow speeds, or at faster speeds, because slow speeds actually cause more anterior shear force. So we're very careful about slow speeds post-op in an ACL. We'll talk about this a little bit more when we get into some exercises, but that's an anterior shear stress we have to be careful with post-op ACLs. And then with knee braces, there's a variety of knee braces. They do provide some proprioceptive feedback, but they're not shown to decrease risk of injury. So if an athlete would say, well, should I wear a brace on my knee post ACL surgery? That's usually a surgeon's preference. And if they do for a few months, it's to protect the knee or to protect it during a high velocity sport. So maybe a lineman would be put in a knee brace, but they are not really shown to prevent or decrease the risk of injury. So there's a lot of controversy about the use of knee braces. All right, so when we go on to general principles, here's some ideas that we might depend on in order to increase flexibility. So if our orders say we need to increase passive range of motion to knee flexion, this is the way that we could do it. The person could kneel and actually drop their high knee back towards their heels. So they're sitting on towards their heels, so they're really, the upper body is moving over the knee, which is really passively just sitting there. Another stretch is the prolonged extension stretch in prone. We use this one a lot in rehab. I tend to actually slide the person down on the table towards their feet, so the table hits them about a few inches above their patella. So they're just kind of free hanging there. You just got to make sure somebody doesn't walk by and whack their leg. That can be fairly uncomfortable. Prolonged extension stretch and long sitting. So this is another way that this can be done. Put a little weight at the distal femur. Sometimes I have done this, but put a backpack strap at this position, and then maybe they'll put books in the backpack just to load it, so we have a little more extension of a hang here to stretch out that posterior knee. We also have quite a few stretches that I show in this section. Quadriceps or rectus femoris stretch. We're going to practice this in class, but when you maintain a posterior pelvic tilt, you should be able to feel this stretch quite a bit more because you're stabilizing the rectus femoris at the origin, which is the AIIS. So if we posterior pelvic tilt, we actually raise the attachment of the rectus femoris. You won't have to go into as much knee flexion before you feel this stretch. So we'll practice that one in lab. So a hamstring stretch, if you're going to prescribe a hamstring stretch, it's best if you have the athlete in a slight anterior pelvic tilt. Again, we're lifting up or bringing up the origin attachment of the muscle, which is the ischial tuberosity, stabilizing it there, and so they won't have to go into as much hip flexion before they feel the hamstring stretch. Adductor stretch, several ways to do that: butterfly, standing, sitting. Iliotibial band stretch. I really haven't found a good stretch for the iliotibial band. There's a couple shown here. This guy in the upper left is supine, trying to keep his pelvis flat and in the frontal plane as he stretches the leg across. Not a great stretch. I think you'd have to be pretty tight in order to feel that. The one on the bottom right is the one that's prescribed currently in the literature as being one of the better iliotibial band stretches. So this guy is stretching his left leg, so the leg that's behind is being stretched, stays in the frontal plane, and then just does a side bend to his right while he kind of laterally displaces his hips in the other direction. So you'll see that there's just a lot of connective tissue here in the iliotibial band. So you just don't feel that stretch very much like you do in a typical muscle. I put a picture up here of a CPM, which is a continuous passive motion machine. These are used a lot post-surgically. And if somebody asks you if, boy, if I have a choice to use this, should I do it? I would recommend definitely. They put these on right after the surgical procedure is completed, especially in total knees. They're used to some extent in ACLs, but it can get the knee moving right away before the person even comes out of anesthesia. So moving on to active assisted range of motion exercises, heel slides are a good one. For active assisted, wall slides, so they let that left leg come all the way down the wall, and then they'll hook underneath the left leg with her right leg and bring it back up into an extended position, and then start the process all over again, letting the foot slide down the wall. Seated knee flexion, so in this picture she's actually pulling her left foot back with her right, which is okay. I think it's what would be an easier thing is to maybe just hold her left leg there with the right and then scoot her body forward up over her knees. So she's just sliding forward on the mat. And I usually tell athletes if they're going to be sitting for a long time in classes or something, this is a great way to work on their knee flexion. Range of motion on the stationary bike. They don't have to be able to go all the way around. They can go forward and then put a little stretch on it and then pedal backwards and put a little stretch on it. 90% of athletes will go around fully on the bike when they're working on range of motion backwards before they'll go forwards. And it's primarily because they're compensating with the hip. It's easier to cheat when you're coming around in the reverse or backwards position on stationary bikes. They'll end up going backwards first. All right, if we try to increase range of motion through flexibility or stretches and we still don't notice an improvement, we might move to joint mobilizations. So on your sheet, I remind you that the capsular pattern is flexion is more limited than extension. In the capsular pattern, a loose packed position is about 20 to 25 degrees of flexion. Closed packed position is full extension with the tibia in external rotation. And remember, we've got a concave surface moving on a convex surface. So this picture is just working of the tibiofib. So between the tib and the fib, she's moving the fibula anterior and posterior. This is kind of a fine movement. We aren't going to get a whole lot of flexion or extension with this mobilization, but we might be able to get just a little bit more if we're missing some end ranges. Patellofemoral joint mobs. Post-surgically, we'll do a fair amount of these, making sure that scar tissue isn't building up. So we're doing a medial glide, an inferior glide, and a superior glide. I actually limit how much lateral gliding that I'll have a patient or an athlete do because that's the direction that they can sublux. And post-surgically, they typically have enough swelling in there that their VMO is not firing at a normal force, and so we don't want to stretch them too much out lateral and predispose them to a subluxation. So there's a straight distraction picture. Aren't doing any glides yet. There we've got an anterior glide working on improving extension. There's a picture of a tibiofemoral posterior glide working on some flexion, starting in resting position. Medial, tibial, anterior glide, working on some external rotation, that that end range. When somebody goes into full external or extension, they'll go into a little bit of tibial external rotation, the screw home mechanism. So sometimes we'll do an anterior medial tibial glide too. So here's another position. We're doing a posterior glide though here, making sure we can unlock from extension and move into a flexion movement. All right, moving into muscular strength, we can usually start it early, even if the muscle is immobilized and non-weight bearing, because we can do isometrics fairly easy. We can add exercises for the trunk, hip, and ankle. Typically, if somebody's been immobilized for a knee injury, these joints also are going to suffer and see a decrease in strength. There shouldn't be any pain or swelling during or after the exercises, within limits. And then just be careful in adding exercises. If you add too many at one time, we can't identify the cause of an inflammatory response if there is one. So just a few at a time. So we start off looking at isometrics. This is one way that you could do quadricep sets, just tightening the quadricep in a prone position. Here's a position on supine to do a quadricep set or a hamstring set. In this position, and I might note that when we're doing ACL rehab, we talked about just being careful of doing a lot of quadricep sets. So in ACL rehab, we'll have them do a hamstring contraction or set first to hold that tibia in a posterior position, and then they superimpose a quadricep set or contraction on that at the same time. Maybe hold it for 5 seconds and then relax. And again, we're trying to protect the graft so it doesn't get just tugged on too much with repetitive quadricep sets alone that might loosen up that graft. Straight leg raises or SLRs, and can be done in obviously usually the 4 positions of flexion, extension, abduction, and adduction. When they do abduction, make sure that they're working glute med and not TFL. TFL is rarely if ever weak. So make sure that they're going into a little bit of extension with their abduction. They've got the femur externally rotated and they're feeling it in the posterior part of the hip. Here's a short arc quad, so she starts with her heel down on the table, contracts the quadriceps, and extends the knee at the same time. Full arc quad is if the knee starts down in 90 degrees and you extend into 0. You wouldn't have to have any resistance in order to call it a full arc quad. Hamstring curl can be done in several different positions. If you remember when we talked about active insufficiency, we talked about if you have a bench that they're laying on flat, that puts them in active insufficiency position. But if they're seated and start with their legs extended so that the hamstring is on a little bit of stretch, then that's physiologically the best position for them to do hamstring curls in. But we can do them in prone, standing. You can make use of a lot of different positions. Oops. All right. Terminal knee extensions or Don Tigneys is if the person stands with their knee in slight flexion. TheraBand is around the posterior knee, and they just simply move into knee extension. You have to be careful, though. Somebody post-surgically can really cheat on this and do this entire motion with using just their glute and never contracting their quadricep. They have a lot of motion going on at their hips, so just watch that they don't move a lot at the hip. They may even want to have some tactile input on the quadricep to make sure that the quadricep is doing the actual motion. Leg press. In rehab, when we're using the leg press, oftentimes we're actually using it to increase some weight bearing, but we're starting to move into some eccentric work. So if this person were in a rehabilitation program, it would be likely that she would be doing the concentrics with bilateral and then doing the eccentric with just a single leg. And we'll try to actually exhaust the eccentrics without causing pain, just because they produce more force, so that means more weight, and we can get bigger, faster, and stronger more quickly post-surgically. So lots of eccentrics done in the leg press, as long as there isn't pain. Here's some pictures of some wall sits. This is how it looks when you do them in Florida. This is how it looks on the right when you do them in Minnesota indoors. Most of you have done wall sits if you've done any athletics. So you could do them against the wall, that's easier. Add the physio ball, that's more difficult. You could have them shift into the surgery leg as we start to increase strength on that, so they have to weight bear more on there. I've had even athletes that have gone into single leg wall sits and worked on those. Plie, this picture came right out of the 70s. I'm not sure that I've ever given plies to an athlete, not even in the 70s. But your book mentions this. We're just going to move on past that. And lunges. Lunges, we can have them being static or stationary, so she's going to go down onto the left and then come right back up. Or she can be progressive, so she takes a step with the left, step with the right. Again, kind of getting towards the end of the strengthening phases in rehab would be where you'd see these. You'll see a lot of these in rehab, step-ups, and then the next phase is doing a step side, and then the next phase is doing step downs. Now I will say that those should be added in that order. We usually don't start with an 8-inch block here, but rather a 2-inch, and do repetitive step-ups, and then increase the height to 4-inch, 6-inch, and 8-inch. If they can do that successfully, 30 reps doing step-ups, then the next progression is to do a lateral step side. These are actually fairly difficult for people that have had some compromise of the quadriceps. We start at a 2-inch again, and they do a lateral step side. So this right leg on this athlete would come down, and she'd actually tap the heel. It would be ideal, tap at the heel and then come right back up. She doesn't actually transfer weight onto the entire other leg, but just a tap, and then she returns to the position. A lot of work for the quadriceps. We try to teach them not to go into a forward bend and recruit the glutes, because we want this exercise to be a quadriceps strengthening exercise. And then the next phase would be a step down, which might not be as difficult strength-wise as a step side, but there's a lot of patellofemoral joint compression forces on the knee that is up, so on her left knee. These might be reserved, or maybe not even done at all. I might not do step downs at all with an athlete that's coming back from surgery, just because there is so much compressive forces done with this. Squats would be added in towards the end. Heel raises, of course, could be added on to the end. On your sheet it says knee bends. Knee bends are a little different from squats, I should mention. You can see on a squat the knee will come forward a little bit in front of the knee. And on a knee bend, you're actually holding onto a table in front of you, and the tibia should just stay exactly perpendicular to the floor, and you actually have to drop or sit back. If you're doing them correctly, you have to hold on, or else you'd fall over. But again, we're trying to decrease patellojoint femoral compression forces with those. Leg press, for some reason I got another picture in here, I guess because they're under the title of machines, so just remember concentric, bilateral, eccentric with one. We can do hamstring curls on machines, and then just a little note on the leg knee extension machine, very minimal use in rehab. There's a high amount of patellofemoral joint compression forces, and we really don't use these, especially in a full arc. in rehab. Now, if I'm having difficulty getting quadriceps strength back in somebody that's post-surgical, maybe late in rehab, I might be starting to do some short arc quads, so starting from like 90 to 40 degrees in there and working the quadriceps, but I won't go to terminal extension. And we'll talk about that in the next lecture as to why we do that, but we're trying to decrease patellofemoral joint compression forces. And then the last one is isokinetic exercises, and I think again this picture must have come out of like the 70s by the looks of this guy's short and haircut, but they're doing isokinetic testing. This device right here, you can see strapped in, there's a bar that is added in, and it's holding his tibia from moving anteriorly, so it won't shear forward. So you might see this sometime if somebody's supposed to do an isokinetic test on post-op ACL. They have to add this anterior shear device in. I actually have heard a few horror stories of people that went to do this isokinetic testing 4 months post-op ACL, and they didn't have the anterior anti-shear device on the isokinetic machine, and we're doing some lower speeds for knee extension, actually retore their ACL, which would be horrible. So that is it for this lecture. The next one will be on specific rehab application.